So, what's the genetics behind prostate cancer? What does genetic predispositions mean as it relates to prostate cancer? And what's the deal with liquid biopsies, a term that many of you have heard? What is a liquid biopsy? My conversation today is with the one and only Dr. Eric Klein. We had him here on episode 79 talking about the SELECT trial, which he was the primary author. The SELECT trial looked at selenium and vitamin E relationship with prostate cancer. And of course, I thought that they could have done a better study. And we talked about that on episode 79. But he is the emeritus Andrew Novick Distinguished Professor and Chair of the Urology Department at Glittman and Kidney Institute at Cleveland Clinic. Dr. Klein has many awards in the world of prostate cancer. He's if we have a Mount Rushmore of prostate cancer experts, I would put Dr. Eric Klein on that mountain. He's one of the foremost experts in that area. Currently, he is working on a clinical development and multi-cancer early detection test based on analysis of liquid biopsies using next generation sequencing. We talk a little bit about liquid biopsies as it relates to prostate cancer, and the company that he works for now, or he works with, which is Gallery, they have a test called GRAIL for genetic predispositions to cancer in general. Full swing. This is full spectrum genetics and prostate cancer with Dr. Eric Klein. Let's go. Welcome to the Dr. Geo podcast. I am your host, Dr. Geo, where it is my intention and my goal, my purpose to help you with your prostate cancer situation, or just prostate situation, testosterone, erectile function, and how to live better as you get older, calendar years, that is, of course. Today's guest is Dr. Eric Klein. You might have remembered Dr. Klein from the conversation we had on the SELECT trial a couple of episodes ago. And today we're going to talk about genetics. What is the role of genetics as it relates to prostate cancer? And what can we do about it? How can we know from this thing called a liquid biopsy? What's a liquid biopsy to learn if a man has prostate cancer? Eric, thanks so much for being on. Always a pleasure to see you.
And a pleasure to be back. Thanks for having me.
My pleasure. It's great to have you back. You're one of three that have been invited for a second time. And I think that there will probably be a third or fourth, because I just enjoy having these conversations with you, particularly with your robust history in the world of prostate cancer. People are still quoting your papers and some of your lines, although you sort of moved on to some degree. And now you're with GRAIL, which we'll talk about. So genetics as it relates to prostate cancer, right? So in a very simple way, always remembering that my audience are what I call self-empowered health advocates. So they're not medically trained, although we have quite a few practitioners. But even for practitioners, I tell you, as a practitioner, I always love reminders of how the body works and certain medical approaches, particularly if I'm not practicing that particular approach in any given moment. So genetics, right? So we have about 30 to 40,000 genes in our body. So they've said in a major WAS worldwide, I forgot what that's, genetic worldwide studies. And so we have about 30 to 40,000 genes. Every cell in our bodies have these genes. Genes are, it combines the DNA, two chromosomes together. And there's reasons why we're kind of going a little bit down into some detail. And when there is some sort of defect with these chromosomes, so these chromosomes or the DNA, they help produce certain proteins in our bodies. It's like the recipe, right? And this is, again, for our audience, this is the recipe that helps it. Well, we need a certain protein. So your DNA has the recipe, then your RNA kind of executes the plan from what's given from the DNA. But there's mutations in this DNA sometimes, actually oftentimes, which is a defect where the recipe is not quite the same. When a defect is in a certain way, it causes your cells to divide uncontrollably. And depending on how much it divides, or if it divides, depending on the type of cancer, that is a cancer cell. So cells by nature are supposed to divide and then die off within a year or 2 years, depending on what area of the body we're talking about. If there's a DNA mutation within the nucleus, then it divides uncontrollably, and that's not a good thing for cancer. So it's a good idea to figure out, all right, do we have any of these mutations in our bodies so that we can be more proactive? Then there is this thing called liquid biopsy, which is like, well, if this comes up positive, if there's some sort of signaling showing that this is positive, then you may have a cancer of some sort. In our case, we're going to talk about prostate cancer. So, Eric, correct anything that I've said that I might have said too loosely for our conversation, and maybe course correct if needed. And B, how does genetics relate to prostate cancer specifically? What are we looking for? And then we'll go into liquid biopsies later on.
Great. So let me expand on your basic explanation, which is correct at a certain level, which is that when there are mutations in certain genes, that certainly can cause uncontrolled cell growth. In prostate cancer, though, those kinds of mutations are very rare in early stage disease, and they don't really accumulate. We don't really see them responsible for driving tumor behavior until the disease is metastatic or castrate resistant. So there are a lot of layers of complexity here, but the one that we are coming to understand is about gene regulation and another layer of the genome called epigenetics.
Mm-hmm.
And so early stage prostate cancer and other cancers, and all normal cells do this, they use methylation, the attachment of a simple methyl group, CH3, for those of you who remember your high school chemistry, to areas of genes that are called promoter regions that turn on or turn off the genes. So one simplistic way to think about it is if you're a cell, a stem cell, an undifferentiated stem cell, and you want to be a liver cell, you use methylation to turn on all the genes that give you all the functions of a liver cell, and you use methylation to turn off all the genes that would turn you into something else. So it's a
So
normal.
more methylation can lead to turning on certain genes, and less methylation can lead to turning on or turning off other genes.
No, it can be, well, yes and no, but it's even more complicated than that. You can
Well,
have
I know,
areas
yeah.
that are hypermethylated, hypomethylated. But think of it, when I talk to youngsters in training about this, I tell them to think of methylation like a light switch. Each gene has a light switch,
Mm-hmm.
and you can use methylation to turn the gene on or off. So that's the way to think about it.
Mm-hmm.
And
And
that's
that is
normal.
epigenetics, isn't it? Epigenetics
It is
is turning
epigenetics.
genes
It's
on and
called
off through
epigenetics.
methylation.
Through methylation. Yeah, that's
Yeah,
exactly right.
right.
And it's an important part. It's a very important part of liquid biopsy technology, in addition to mutations. And we can chat about that later. So there are two kinds of sort of genetic changes to think about. One is in someone who is not born with any pathologic mutations. You can get environmentally caused mutations from aging, from things we eat and drink and breathe and smoke and that sort of thing. Those are called somatic mutations. And there are germline mutations. There are certain mutations in certain genes in what you're born with, the DNA you're born with, which I like to describe as all the things that you can blame your parents for, right? Your bald head, your blue eyes, your gray hair, your body mass index, or
Your
your
poor
body
attitude.
temperature. All, well, I don't know about that. You might have liked, you
we
might have
can't
liked,
we can't blame our parents for that. Oh, you know.
you might be able to, but it's probably not genetic. So there are certain known syndromes, like BRCA is probably the best one, breast cancer ovarian syndrome, that also reflects risk on prostate cancer, that people are born with. So the first attempt to sort of understand this for a patient is, are we talking about germline genetics that I was born with, or are we talking about somatic genetics and somatic mutations that I wasn't born with, but my tumor has acquired? And those are two separate things.
Mm-hmm.
Germline mutations determine lifetime risk of getting a particular cancer and sometimes determine the aggressiveness of that cancer. Somatic mutations occur more randomly and may determine whether you have a cancer that is contained in your prostate, or one that grows locally, or one that metastasizes, or one that behaves very aggressively. And they're measured in different ways.
Germline mutations. Are you familiar with the company Invitae that measures through
Yes,
saliva germline?
yes,
So they were
yes.
just bought out by LabCorp. We got a
I saw
message
that.
this morning. Did you see
Yeah, I
that?
saw that. Yes.
So that's one of the germline mutation tools that I've used in the past.
Yes.
Easy, spit in a cup, send it back, and so forth.
Yes. And there are a number of
Somatic
companies that do that.
mutations.
And yes, You can measure
Yeah, I don't want to
germline
single out
mutations.
Invitae in any way. Sure, there's quite a
But
few.
right, yeah, there are
Um,
others.
Another one was color,
Color, right,
COLOR, right? Although I
right.
haven't seen much of them recently. And the company Myriad has one as well that I think you're
Myriad, Tempus. I mean,
temp-
there are lots of companies that will screen your germline DNA for inherited mutations.
right. Somatic mutations. What are the tools that we have to look for somatic mutations?
Yeah, until very recently, the only tool we had was to do a biopsy of the tumor and sequence the DNA using
Mm-hmm.
next generation sequencing, which is the same technology that's used to sequence the whole genome. Now, with very sophisticated technologies for some cancers, we can detect DNA that is shed from the cancer into the bloodstream or into the urine or into saliva or other bodily fluids in the midst of a lot of background noise. Find the cancer signal in those bodily fluids. That's what liquid biopsy is about. And there's
So
pretty
are these
good.
cells, Eric, are these cancer cells dead? Are they alive? Are they still going? What are they shedding?
They're shedding DNA from the tumor,
Mm-hmm.
and it's a multifaceted process that's not completely understood. So, certainly, cancer cells that die shed DNA into the bloodstream, but there's probably some DNA that comes just from cell turnover. So, tumors that have a higher mitotic rate
Mm-hmm.
tend to shed more cell-free DNA or what's called circulating tumor DNA into the bloodstream. And that can be picked up in little lipid packets called exosomes, which also can include other markers of cancer. And one you mentioned, RNA. And so that's a target signal that some companies are looking at to see if you can detect the presence of cancer or characterize what mutations are in the cancer so you can pick a targeted therapy or determine after treatment whether or not you have any active cancer in you. That's one of the targets they're looking at. But most of the companies are looking at what's called circulating cell-free DNA.
So in some of those companies, we can mention names here because, so that the audience knows what to look for, what to ask for. So some of these companies include Verisight, which is the Decipher test. Is that right?
Well, that's not a blood-based test. That's a tissue-based test.
Tissue-based test.
So
I'm sorry.
yes.
The blood-based test
So
for somatic
yeah.
testing that you're aware of.
Yes. Foundation Medicine and Natera probably have the two most popular ones.
Mm-hmm.
And there are almost any company that sequences germline DNA is in the liquid biopsy space now and may offer a test that looks for a cancer signal in the blood. And
Okay.
generally, those have been targeted on patients who already have known cancers to help characterize the cancer again at the time of diagnosis to help decide what treatment to help give prognostic information or again after treatment to determine if they have what's called minimal residual disease that's only detected in the blood and not detected on x-rays.
Mm-hmm. Actually, we'll skip over tissue-based DNA just because we're going to have plenty of conversations with
Okay.
other interviewees and experts on the topic. Let's go right into the liquid biopsy. So the goal here is to assess whether you are, and you'll correct me here, if you're at a high risk of having a particular cancer, or is it that they do have a cancer on a specific tissue and without the use of an actual needle biopsy. So that's why they call it liquid biopsy. Go ahead and again course correct and expand on that if you.
Yeah, so the answer is actually both of those
Mm-hmm.
circumstances. So the more established paradigm are in people with known cancers. Let's talk about that first.
Mm-hmm.
And when you assess the bloodstream, and let me make clear that liquid biopsy applies to any body fluid, but the tests that are out on the market for most solid tumors are blood-based, although there are some urine-based tests for bladder cancer. So once you're diagnosed with a cancer, and let's say you've had a biopsy to prove, let's say you have lung cancer, there are a number of issues that arise. One is, are there specific somatic mutations in that cancer that might respond to a drug that attacks that specific mutation? That's called targeted therapy. And that's a very useful strategy now for determining what treatments to use, and particularly in lung cancer, but other kinds of cancers as well. So that's one use, is helping to pick targeted therapy. A second potential use is to prognosticate. It turns out what we've learned is that cells that shed a lot of cell-free DNA and put a lot of DNA in the bloodstream seem to be biologically more aggressive than cells that don't. And it's a fundamental biologic property of the tumor as to whether or not they shed. And so all the biologic processes that we know about that are associated with aggressiveness, so high cell turnover, that's called mitosis, invasion of surrounding tissues, new blood vessel formation, that's called angiogenesis, all of those.
I'm super excited about today's sponsor, which is Mr. Happy XY Vigor, a formulation to enhance testosterone levels and promote sexual function. Mr. Happy XY Vigor, or XYVGGR, was formulated by yours truly to optimize male hormones and free up testosterone and improve sexual health. It also has an abundance of L-citrulline, which helps dilate and open up blood vessels so there's more circulation going into the pelvic area for better erections. Try Mr. Happy XY Vigor today at immrhappy.com/products/XYVGGR.
All of those are associated with higher levels of cell-free DNA in the bloodstream. So there's emerging data that suggests that you can use that potentially to predict prognosis. And there's even some talk about incorporating that kind of biomarker into the TNM staging system. That's very early talk, but we probably in 5 to 10 years will have a new staging system that includes blood-based biomarkers.
Sure, and I'm sure artificial intelligence will play a role in that.
No doubt. Mm-hmm. The next potential place where monitoring what's going on in the blood is useful is monitoring treatment response. So if you have a tumor that's shedding, let's say a metastatic tumor that's shedding a lot of DNA into the bloodstream, if you give a certain treatment and it's effective, you should see some of the tumor or all of the tumor killed, and so there should be less DNA in the bloodstream. So there's a lot of investigation into that. So that might be a way of monitoring someone's response to therapy and determining if and when someone has a new clone of cells that has different mutations that are starting to grow. You could detect that signal in the blood, and that might be a time to add additional treatment or switch treatments. And so I have this big, hairy, audacious idea in my mind that someday we will have an Apple Watch-like device that straps to your wrists that transcutaneously through the skin can monitor circulating tumor cells or circulating cell-free DNA continuously, as long as you're wearing whatever the device is, and give a data feed to your physician so that when your physician comes into the office that day, they can turn on the computer, download your data, and look to see if you're still responding to the medicine that you're on and send you a message that says, let's stay the course, or can look to see if there are new cells that are resistant that are emerging and time to come in and start something new. That's a very futuristic goal. I don't know if we'll ever get there, but that's the level that we're thinking about this.
I love it. As you can imagine, a person that does what I do, which is lifestyle medicine, exercise and things. For the last couple of years, I've been doing prostate cancer work from a naturopathic and lifestyle perspective for 20 years. For the first 15 years, I was more focused on, these are how these lifestyle approaches can help you with your overall health and lower your risk of dying from other things. Within the last 5 years, just because of what I've seen clinically and the data that's available, I said, what's the anti-cancer element of eating well and so forth, And so that would, for me, if I can tell, do this protocol and some sort of device can tell us if you're in the right direction or not as well, along with the therapies, that would be amazing for me. With CGMs, right, glucose monitoring devices,
yes,
you can see it's great feedback.
Right.
You eat this,
yes,
glucose goes up.
Yes.
You eat this, go walk for 10 minutes,
right,
and see how fast glucose goes down. You eat this, you walk slow. You eat this, you walk fast. You eat this, you go up and down stairs. You can see the response right away from certain lifestyle behaviors.
So conceptually, it's the same idea. You could see the response if you're talking about cancer. If you could have some sort of continuous or even intermittent monitoring of what's going on in the bloodstream, you can see what the response is to the therapy or other lifestyle or even diet. I mean, potentially you could look at diet and exercise and how that
Potentially,
modifies.
sure. I
Yeah,
mean,
all of that.
yeah,
All of
sure,
that. Yeah,
sure.
absolutely.
It treats the microenvironment. So,
And then the last way that
hmm
monitoring the blood for DNA, for tumor DNA, is useful is after treatment. So let's say, you present with a stage 2 colorectal cancer and you have surgery, you have chemotherapy and radiation, and then you have surgery, and your physical exams are negative, no sign of cancer, and your CT scans are negative, no sign of cancer. But we know that some patients still recur. And so now we are in the space of monitoring people for what's called minimal residual disease or molecular residual disease. So after treatment, you do a blood test
hmm
and you see what DNA, or if you've done the same test pre-treatment, what mutations in the DNA are still present in the bloodstream. And there's pretty good evidence for a lot of different tumors now that show that if you have a molecular signal of DNA, tumor-related DNA in your bloodstream after treatment, you're at higher risk of relapse.
mm.
And so there are a number of clinical trials that have been done and are in progress, particularly for colorectal and lung cancer, to determine if people who have DNA molecules in their bloodstream benefit from intensified adjuvant therapy. So
Mm.
more chemotherapy after treatment.
Mm.
So far, that
And then weigh the benefits versus the risk of that, right?
exactly. And that might be a place to use immunotherapy because immunotherapy can
Mm.
be quite effective, but only at very low tumor burdens. So if the only cancer you can detect in the body is a measurement of cancer related DNA in the bloodstream, that's a pretty low tumor burden
Mm.
if you
Mm.
can't see it or feel it. And there's a lot of interest in not only targeted agents, but immunotherapy and that. So, three ways, just to summarize, three ways that a liquid biopsy, and once you're diagnosed with cancer, can be helpful is picking the right treatment, monitoring response to your treatment, and then determining whether or not you're cancer free or might benefit from additional adjuvant therapy. And
Yeah,
those
correct.
are all those approaches are maturing very nicely.
And where are we now? How can we use it today, 2024?
Well, so if you're newly diagnosed with a cancer, my advice to a patient with any cancer would be to have the whole cancer genome sequence, get a tissue biopsy if you can and have it sequenced, and to have a blood-based liquid biopsy test to determine what mutations might be driving the cancer, not only for prognostic information, but to help decide on what the appropriate treatment is.
So we can't use it yet for treatment purposes or
Well, you
to.
can. No, absolutely, you can for certain mutations in many different tumor types. You can use it, and it's reimbursed for that reason for targeted therapy for
Oh, good.
lung cancers, leukemias.
Oh, good.
Yes.
Eric, what's the risk of getting a liquid biopsy, right? Because it certainly in the world of prostate cancer, and that's a world I live in, I only look a little bit at other cancers to see how it relates to prostate cancer. So
Yeah.
if I'm an expert in anything, it's not cancer overall, it might be just prostate cancer. But we know in the world of prostate cancer that we don't always want to find all prostate cancer, right? What's the risk? Meaning what? Meaning that if you do a biopsy and it's cancer, but it's such low risk that you shouldn't have to worry about it. I don't want to find these cancers. So what's the risk of a liquid biopsy coming up positive for signaling and now making us anxious for something that we shouldn't worry about?
So now you're talking. It's a good question. Now you're talking about a different space for liquid biopsy, which really isn't a liquid biopsy. It's a blood test to determine whether or not you have cancer, and that's the screening space. Right? That's healthy
Mhm.
people who don't have any signs or symptoms or clinical suspicion of cancer. And the question is, can
Which is
you
how
look
I've
in the
used it, by the way, so far,
yes,
at least the Grail.
yes, which is what Grail's Gallery test is intended for, the screening space to
Yeah.
screen people who are at elevated risk of cancer because of age or smoking or a germline genetic mutation that they've inherited or other risk factors, and there are many others. So that's different from what we were just talking about. And let me tie this back to the epigenetic story,
Yep.
because this is why this is important. Really early stage cancers, and particularly prostate cancer, don't have many mutations. What they have is altered epigenetic signaling that turns on the wrong genes and turns off the right genes. So a cancer cell, again, this is an oversimplification, but it's a good way to think about it. Remember I said a liver cell turns on all the genes to make it a liver cell and turns off everything else. A cancer cell uses methylation to turn off all the genes that would prevent it from growing and turn on genes that allow it to grow. Mm-hmm. And that methylation signal can be captured by sequencing. And Grail's test uses what's called a targeted methylation approach. So across the entire span of all the chromosomes, the whole genome, we look at 1 million different methylation signals in the blood. And what we find is that people with cancers of all sorts have a shared signal that indicates that it's cancer independent of where it came from. And the second thing is using machine learning, artificial intelligence approach is if you have a cancer signal detected with this test, you can predict where it's coming from, what we call the cancer signal origin, or what some people call the tissue of origin. You can predict with 90% accuracy what kind of cancer it is.
So a lung cancer signaling would not be confused with a liver cancer. It's probably 90% chance that it is indeed lung cancer.
Correct. Now, having said that, a lung cancer and a liver cancer share a certain methylation pattern that says, I'm not normal, I'm cancer. And it doesn't matter where it came from.
Yeah.
But there are other patterns that say, I'm a lung cancer or I'm a liver cancer. So there is a little crosstalk there, but again, with about 90% accuracy, we can detect that. So let's think about how a test like that might be used in the general population before we talk about prostate cancer. So the main risk factor in the general population for cancer is age. Despite the fact that we've heard a lot about the increasing relative incidence of cancers in young people, the absolute number of people under 50 in the United States who have cancer is very small still. So we target people who are 50 and older because if you look at SEER or other epidemiologic statistics, the incidence of cancer starts going up at age 50 and it goes up every year as we age. It goes up, your risk of cancer goes up 2 or 3%. So age over 50. And again, smoking, obesity, diabetes, cirrhosis, immunosuppression, transplant patients who are people with prior cancers who are currently cancer-free are at risk for that cancer to come back. And they're also at risk for a second different cancer because of the treatment they had, radiation, chemotherapy. So all of those people are at elevated risk for cancer. Okay, so let's take a general population. And we did this study called Pathfinder, where we took 6,600 people who were not under clinical suspicion of cancer. We did the blood test, the Gallery blood test on them. And we returned the results to their physicians and to the participants. And as predicted, we saw that about 1.4% of the study population had a cancer signal detected. What does that mean? It's like getting a positive mammogram. It says you have a spot, you have a signal on your mammogram that suggests you might have cancer. What do you do next? You need a diagnostic evaluation to prove that. You need to have a biopsy done or maybe some other imaging study.
Yeah, so if it's a colorectal signaling, then see your gastroenterologist for follow-up, or breast cancer, see a breast cancer expert, so forth.
Correct. So if you have a cancer signal detected with Gallery, the next step is a diagnostic evaluation to prove the presence or absence of cancer. It's no different than a positive mammogram in that respect.
Right. It's not it's not a method to diagnose. It's a method to say, hey, there's something suspicious here. See an expert and let them follow up with you.
Exactly. Yeah. The difference is that Gallery can detect dozens of different kinds of cancers. It doesn't just detect one kind of cancer. The other difference is this. The positive predictive value, the likelihood that someone with an abnormal mammogram actually has cancer, is 5%, 4.5%. So that means 1 in 20 women with a positive mammogram undergo a diagnostic evaluation. All 20 undergo a diagnostic evaluation, but only one of them has cancer. So there are 19 false positives, roughly. For Gallery, the positive predictive value, again, for mammography, it's 4.5%. For Gallery, it's 43%. So it's 10 times better than mammography. And so the point being is that if you have a cancer signal detected on a Gallery blood test, you have almost a 50-50 chance of having cancer, as opposed to a mammogram where you only have a 5% chance of having
Right.
cancer. So that shows the power of the technology, looking at targeted methylation to detect cancer and predict where it's from. And the prediction, as you mentioned already, let me just finish the thought, please, is that there's a two-level readout for our cancer signal detected test. It's cancer present. That was nice, the balloons.
I have no idea.
It's a setting in the Zoom
Okay.
that recognizes hand gestures. Anyway,
Right.
back to the point. So a Gallery test report will have cancer signal detected, yes or no.
Mm-hmm.
So if it's cancer signal detected, yes, then you will also get a second piece of information, which is the cancer signal origin. What's the likely origin of the cancer? And that helps direct efficient diagnostic evaluation. So you said it, if it suggests a colorectal cancer, then colonoscopy is appropriate. If it suggests a kidney cancer, CT of the kidneys. If it suggests head and neck cancer, generally a referral to an otolaryngologist for an exam, a laryngoscopy, and a CT scan, and that sort of thing.
Again, let me pose the same question I posed earlier as it relates to prostate cancer. So 43% in a breast cancer scenario of coming up positive and more specific than a mammogram. What are the chances out of those 43% that we're finding something that's so irrelevant that we shouldn't find?
Yeah, actually, we have a strong belief in a lot of clinical data now to suggest that this particular test, this particular targeted methylation assay that we use, is not going to overdiagnose indolent cancers. And I will give you some specific information about prostate cancer in that regard, but let me talk more generally. What we saw in a larger case control study that we did of 15,000 people, 10,000 of whom had cancers, was that for any given cancer and for any given stage of the cancer, if you had a cancer that was not shedding DNA into the bloodstream, you had a far better prognosis than individuals who shed cancer into the bloodstream. And for the cancers that shed DNA into the bloodstream, you're still curable, just as well as the general population that hasn't had a blood test there. So some people have thought that if you have DNA in the bloodstream from a cancer, that you have micrometastatic disease that's not curable. That's clearly not the case. That's not true. But the distinction we're trying to make is that you can have a prostate or a breast or a lung cancer that doesn't shed much DNA. Even if it's a stage 4 cancer, your survival is better than the same histologic cancer that sheds DNA. Recall I said earlier that it's a fundamental biologic process that mirrors biologic processes that we know indicate aggressive cancers, high mitotic rate, invasion, new blood vessel formation. So that's why we don't think that this is going to overdetect a lot of cancer. A lot of indolent cancer. So I can tell you in the Pathfinder study, again, the prospective study of 6,600, we missed some cancers. Gallery missed some cancers in that. And the cancers we missed were low-grade prostate cancer, low-grade breast cancer, stage 1 lung cancer, thyroid cancer, those sorts of things that tend to behave indolently. And we have looked specifically at prostate cancer. And the reason we did is this is really an important question. Prostate cancer is probably the most overdiagnosed cancer that there is. Secondly, Gallery is intended for screening adults aged 50 to 79. Well, if you think about the age-specific incidence of prostate cancer, it peaks in people aged 50 to 79. So in the context of a primary care practice where men are coming in for primary care and are going to be screened with Gallery, we need to know how it performs specifically for a very prevalent cancer, prostate cancer in that population. We're not using Gallery to supplant PSA, and I still am a believer in PSA screening. And so this should be, in fact, let me state clearly that Gallery is intended as a complement to all current standard of care screenings. It is not meant to replace mammography or colonoscopy or cervical cancer screening or low-dose CT for lung or PSA. It's meant to be used as a complement. Okay, so we looked in our case control study where there were 420 men with prostate cancer. What we found was that overall the detection in that population of these 400 cases was we only detected about 11% of them. And the reason for that is that the largest number of cancers were low-grade cancers. And so we detected with Gallery no grade 6 cancers, none Gleason's grade 6 cancers, 2% of Gleason's grade 3+4 cancers. So favorable intermediate risk. Those are probably the two kinds of prostate cancer that are the most indolent that can go on active surveillance. So if you're screening
So
healthy
zeros, you didn't detect any Gleason 6s and
correct,
2% Gleason 7s 3+4, which
correct,
some may argue that's low intermediate risk.
correct.
Yeah. Okay.
So
So the
when
9% that was detected were what?
let me just make the point that in the general healthy primary care population where Gallery is used as a complement to standard of care screening, we are not going to add to the overdiagnosis of prostate cancer. That's what that data says to me. Okay. About 5% of Gleason's 4+3 were detected, 17% of Gleason's 4+4, and 40% of Gleason's 9 and 10. So it's an interesting observation, and there's not much literature on this in the medical literature, but a little. There are a couple studies that show that relative to other cancers, prostate cancer, even when high grade or advanced, doesn't shed much cell-free DNA into the bloodstream.
And you mentioned earlier, which I didn't think I knew that, and this is why I love podcasting, because, well, first, once you think you know everything, you should retire, and so that's number one. Number two is
For sure.
I get to speak to people like you at shedding more knowledge, no pun intended, into the topic, particularly of prostate cancer. So if you have stage 4, let's go back and more general outside of prostate cancer, just general cancer.
Yeah.
If you have stage 4 cancer, but you're a non-shedder, a term that I
Yes.
just used, probably
No,
cheated
we
out.
use that term. No, that's the
Okay,
right
a
term.
non-shedder.
Non-shedder. Yeah.
Okay. Then your prognosis is better
Yes.
than if you are a stage 4 and you are a shedder.
Correct.
Okay. Do we know if you are, if you're a stage 4 non-shedder, is that a better prognosis than a stage 1 shedder or a stage 2 shedder?
We haven't done that head-to-head comparison. It's interesting. Stage still dominates, probably. If you look at the overall survival rates for non-shedding stage 4 tumors, they're still worse than shedding stage 3 tumors are, probably, and shedding stage tumors are. And the important issue is we may ultimately, I mentioned this, that if we can add this kind of biomarker to the staging system, the TNM stage, which is based on anatomic extent of the cancer, may be supplanted by a biologic stage. You're asking a very good and intuitive question, which gets to my comment previously about adding a blood-based biomarker to our staging system. It may in the future matter less what the anatomic extent of your cancer is, as opposed to what its biologic state is. And so I have said this a long time about prostate cancer, and I know you're going to have some discussions with others about biopsy-based gene expression profiling for early stage prostate cancer and selecting active surveillance. We should be making decisions based on the biology of the cancer, not so much what it looks like under the microscope, because what it looks like under the microscope has some biologic information, but doesn't capture everything.
So the end of the Gleason system?
Well,
potentially?
Potentially, probably an addition to the Gleason system. So the point being that histology tells you something about the biology of the cancer, but it doesn't explain everything. And I can tell you we have some unpublished data with Oncotype that shows that even after the best pathologists look at current biopsies using the latest criteria, looking at cribriform histology and that sort of thing, Oncotype still adds significant information that would be helpful. And probably the other, I pick on Oncotype only because that was the one we studied. The other markers also probably add that same value there. The point I'm trying to make is a bigger one. We have all grown up in an era where cancer treatment that wasn't metastatic was determined by anatomic extent. And we're moving rapidly into an era where cancer treatment will be determined by the biology of the cancer and not so much where it's located. So some people have advocated that using liquid biopsy kind of technology or other sort of biomarkers, that you don't need histology to decide how to treat a
Mm,
cancer.
mm.
Leukemia that has a mutation in the ALK gene responds roughly the same to a targeted ALK agent as a lung cancer with the same mutation in the ALK gene. So it doesn't matter whether it comes from a blood cell or from a lung cell at some level.
Fascinating. This
Yes,
is
it is.
the same with the in prostate cancer. So I had Scott Egner, who is a proponent of not even calling Gleason 6
Yes,
prostate cancer. Then I had Adam Keibel, who says, no, Gleason 6 is cancer, right? So this is
yes,
beautiful war on whether or not we should call it Gleason 6 cancer or not. And I think I think what one is saying is biologically it's just not cancer. And the other group is saying, well, histologically, it is cancer,
yes,
and that is exactly the conversation, right? So, do we call it cancer based on biological presentation or histological presentation?
right. Agreed. And
Yeah,
it's
yeah,
a very interesting debate. And I would
yeah,
say
yeah.
a Gleason 6 that has a high Decipher or Oncotype or Polaris score is a cancer that needs treatment.
Interesting. So, and that's God. We can go
And
so
they're
many
not very
direct.
common. They're not very common.
They're
At
not
least
very
they're
common.
not very common, but they do exist.
High
And
volume, very high volume, multiple
yes,
course, Gleason 6, high risk on one of these genetic tests, BRCA2 mutation
well,
from a
so that's,
germline. Yeah,
yeah,
but
BRCA
that
is a different,
increases, that
yeah,
increases because it's a very, I see well, as you can imagine, many of these patients come to me to say, well, you don't need, just do this natural protocol, right?
right, right,
When I do my due diligence, of course, I'm saying, well, let's look at your risk. So I see these Gleason 6s and I know germline mutation is different, but they do come with BRCA2 mutation,
yes,
high
yes,
volume Gleason 6,
yes,
high risk genetic testing of the tissue. And as well, in your case, it's very clear that we should seek medical treatment along with
yes,
other approaches, natural
yes.
approaches as
I
well.
agree.
Fascinating. So I've had a couple of Gleason 9 prostate cancers that come up negative and with regard to the Grail test. So no
So let
signaling
me ask.
showing, and then we biopsy and there's a Gleason 9. Go right ahead.
So let me ask so that doesn't surprise me. As the data I just showed you,
Yeah.
this test doesn't detect all green.
60% may
Right.
miss, yeah,
And
may miss the Gleason 9.
and the point being that prostate cancers don't shed compared to other cancers a lot of DNA. But there's one other piece to the story before I ask you about the specific case. There's one other piece to the story on prostate cancer that I want to emphasize. And this case raises an issue here. So recall I talked about the ability of Gallery to predict a cancer signal origin. So despite the fact that we don't detect we don't detect every prostate cancer there, if you have a prostate cancer signal of origin, that was 90% accurate in this study. And so what I would say is, if you're again in a primary care or a wellness setting, screening a healthy man not suspicious for cancer with Gallery, and you get a cancer signal detected and a CSO that says prostate cancer, don't ignore it, because the prostate cancer that patient is likely to have is going to be a high-grade cancer.
Interesting.
That's different
Yeah.
from using it as a screening test for prostate cancer. So what was the context, please, of this patient where you had a negative Gallery test, but he had Gleason 9 prostate cancer? What prompted the prostate biopsy? Which came first?
75-year-old male, active surveillance for 20 years for Gleason 6 found 20 years ago, no biopsy till recently, which 20 years ago, things were so different, right? Who knows if he truly had just a Gleason 6, all right? But that's what we have.
Well, he's 20 years down the road without treatment, so it probably was a Gleason 6.
Right, or might have had something else. My understanding, I don't do biopsies, but just the way to do them in this day and age is so different and so
Yes.
more specific and targeted than ever before. PSA hung around 6 for a while, 6.3, 6. And then we did an MRI that showed a PIRAD 4. Okay. So the MRI kind of triggered it. And the reason why we did an MRI is because PSA climbed up a little bit, and not for a 75-year-old man, but this is that's the other thing that when you look at guidelines, right? Very ultra healthy 75-year-old man. This is, biologically probably 50 years old.
Yeah.
So that's what triggered the biopsy.
So why was the Gallery test done? Just as a general screen for cancers?
Correct.
Okay.
So the population that I see, which I
Yes.
understand, is I don't
Yeah.
want to. I don't want these needles up my ear. I don't want these needles, but only if we do the due diligence
Yes.
to suggest, yep, you do need a biopsy. Then right.
Yes.
So there was so what prompted me was to look at a gallery and say, well, let's see if there's something comes up. The
Okay.
reason why we still went forward is because his PSA he looked a little nervous. I said, look, MRIs are indolent, and
Okay.
will give us some more. And I want to know the size of your prostate. Maybe your PSA density is really low.
So I would say that's not the intended use of Gallery.
Mm-hmm.
The intended use of Gallery is not to determine the aggressiveness of a known cancer. The intended use of Gallery is to screen people.
No, this was
for
before
cancer
the
screening.
diagnosis.
Okay. All right. Fair enough.
Yeah,
Okay.
this was before
Fair
the
enough.
diagnosis to lead me into biopsying or not.
Yes.
But we did it anyway because of, by the way, he got this test. This particular case, he got this test somewhere else. A lot of functional integrative medicine doctors are all up on Gallery.
Yeah.
They're
No,
utilizing
that's
it
fine.
quite a bit, as
That's
you can
fine.
imagine.
But I want to make the point that the
Yeah.
intended use of Gallery is
Right.
screening people, who are not under clinical suspicion of cancer. Now, having said that, I'm not surprised that the Gallery test did not find his cancer. My guess is, since it's been present for 20 years without treatment, even though it looks aggressive under the microscope now,
Histologically.
it's a relatively indolent cancer relative to other prostate cancers. That's what I would predict.
So he's a non-shedder, perhaps. He's probably a non-shedder. And even though histologically, Gleason 9,
right,
he probably can outlive his cancer. Now, of course, with a Gleason 9, no one feels comfortable with doing active surveillance anymore. Once that cat is out of the box, then we have to do something. And he's going to get it surgically treated, and he should do fine.
Yeah.
Is it possible? Let me frame this question differently. One of the things that prompts a certain type of treatment over another in prostate cancer is whether or not the tumors are encapsulated or if they're outside of the capsule.
Yes.
If there is tumor outside of the capsule, should we assume that there will be signaling there with a Grail test or not? Or is it the same situation? Maybe it's outside of the prostate, but non-shedder. Is that possible?
Yes, it's possible. And no, you should not assume that it signals if it's outside the capsule. So if you're talking about microscopic spread through the capsule. So no. So in the same data set I talked about, these 420 men, Gallery detected only about 15% of stage 3 cancers, which all have this microscopic spread extracapsular extension.
15%?
So no. Yeah. Mm-hmm. And it's much higher. It's 81% for metastatic cancers. So this is not a good staging tool for prostate cancer. And again, that's not the intended use. This is really important. I want to emphasize this. Mm-hmm. The age-specific incidence of prostate cancer in the general population overlaps the intended use population for Gallery. Gallery is intended to screen healthy people who don't have any particular clinical suspicion for cancer. And we needed to know how it performs for prostate cancer. So it's not going to overdiagnose low-grade disease. It won't find all the biologically significant cancer. But if you have a cancer signal detected that says prostate and the cancer signal origin says prostate, don't ignore it, because that's likely to be a biologically significant cancer if it's detectable.
Eric, can we say anything? So same scenario, cancer outside of the outside of the capsule, non-shedder, prognosis probably better, though it's outside of the capsule?
Yes.
We're sort of guessing. I'm okay with that. But
no, the data is suggesting that. I wouldn't say it's a firm scientific conclusion, but we have, because it needs replication. But from this large case control study we looked at multiple cancers, including prostate, and non-shedders, grade for grade, stage for stage, do better than shedders.
Yeah, across
for almost
board.
Every cancer. This is a fundamental biologic property that has been revealed by using this targeted methylation assay, and we're working to understand it and to work with pharma partners and others to determine how this can be exploited clinically. My
Right.
guess is,
With regards to
yeah,
treatment,
right.
we don't want to
And
put out guys on hormone
right.
therapy if we don't have to.
I would
Androgen receptor blockers, and we don't want to do that.
And in order to make those decisions, you need to do the clinical studies, right?
Yep.
So let's go back to the MRD space, the minimal residual disease space. One could assume, knowing that after treatment, that people who have a DNA signal in their bloodstream are more likely to relapse, one could just automatically conclude, well, I should do that test on everybody and just give them additional adjuvant chemotherapy. But the reality is you need to do randomized trials to prove that the therapy makes a difference. And so far, at least for colorectal cancer, it hasn't made a difference. So those studies still need to be done.
Yeah. Yeah.
But it's a really interesting biologic observation that I think
It's
ultimately will
fascinating.
pan out, and ultimately will somehow be incorporated. A biologic signal based on
Yeah.
blood or other body fluids is going to be incorporated in
Sure.
our staging system, I think.
Algorithms, right? So Shutter,
Yes.
yes, no. Okay,
Yes.
no
Correct.
here, yes here,
Exactly.
and then
Right.
so
We'll
lovely.
get there. We'll get there, but there's a lot of work to be done before we do.
Well, at least now I have something to know. I know what to ask or what to look for, right? I
Yes.
didn't I, when I'm trying to evaluate who needs what. I'm looking for other things, not whether or not if they're shedders or not. Can a tumor go from being a non-shedder to a shedder? So, in other words, how often do we need to order this to see if things change?
Yeah. I don't know about the first question. Can a tumor go from a shedder to non-shedder? I mean, non-shedder to shedder. My guess is yes, but I don't know that for sure. That hasn't been studied. So how often should we do this? We do have some data on this. We have a study done on a biobank from the American Cancer Society where we had a whole set of patients, several thousand who cases and controls, some who got cancer, some who didn't. We had serial blood samples up to 8 years prior to their diagnosis, and we sampled them serially. And what we saw was that the average cancer signal comes up and is detectable in the blood about a year before diagnosis. For some cancers,
Mm,
like low-grade lymphomas, it's several years prior. For some aggressive
mm,
cancers, along the lines of ovarian and maybe pancreatic cancer, it comes up quicker than that. So it's possible that you could see someone on January 1st, do a blood test, not see a signal, right? No cancer signal detected, and retest them a year later, and they could have an aggressive cancer. And it's not that the first test necessarily missed the cancer. It's very possible that it's a new cancer that started just a few months ago. So
mm.
that is another area of active discussion and discovery work and so forth. But our current suggestion is that Gallery be repeated in people over 50 once a year as part of routine screening as we refine the information that we have and understand that better. It may come, again, this is speculation, it may come to a point that people at risk, highest risk for the most aggressive cancers might want to be screened more frequently than that. But we don't have data to support that yet.
Interesting. What do we do? So where are we as it relates to coverage? So my patients paid, some money, about,
Yes,
I don't know, $800 per test, and they were able
yes,
to, but obviously not
yes.
everybody's able to. So where are we with
Yeah.
coverage?
So we have many employer partners, including healthcare systems, that are offering this at a discounted rate, or in some cases using philanthropic funds or foundation funds to cover this, to make this available to their employees and their patients. Lots of big employers are making it available as an employee benefit at no cost or discounted cost to the employee. The big insurers are following the field closely and as of yet have not established reimbursement for this.
Any idea where we're going? I mean, just from
Yeah.
knowing how the system works and how the whole politics works, and do you think once
Well,
there's more research, I think your research is pretty good right now. Once there's more research, and companies will come and on board and cover it. What do you think?
I certainly hope so. I mean, it takes a whole system to pay attention to this. It takes thought
Yeah.
leaders to say, yes, this is the right thing to do. It takes a very strong clinical trial evidence base to say, yes, these are the benefits and the risks. You should pay for this. And different insurers look at it differently. So some of our most eager users are life insurance companies who
Hmm.
offer it to their beneficiaries, but not what you would think. It's not a requirement to get life insurance. They offer it as a benefit after someone is insured.
Oh, interesting. I would think the opposite. I would think, oh, you got a positive signaling. Well, we're not covering you. We're not covering you.
So the life insurers want to know when they're going to have to pay your death benefit. And so they want to know if you have a cancer signal now that we have insured you.
Yeah.
And if you do, we're going to send you to the medical system so that the
Yeah.
medical insurers assume the initial financial risk. So, there are some, and I say that there are some business considerations here in terms of what the cost benefit ratio is and so forth. There are lots of levels to this. CMS is not required, Medicare is not required to pay for screening tests unless it's established by law. So there are laws on the books that say that you have to pay for mammography and colorectal cancer screening and PSA. There's no law on the books that says you have to pay for multi-cancer early detection screening, although there is a bill in Congress that has immense bipartisan support in both houses of Congress that will permit, not require, permit CMS to cover this test or tests like this. And we also will be starting in just a few months a study called REACH, or the CMS Gallery study, where CMS has agreed to pay for tests for up to 50,000 people up to 3 years of testing. And CMS does its own, risk benefit analysis separate from the FDA. And then we're in deep discussion.
What does CMS stand for?
Center for Medicare Services, Medicare, Medicaid Services.
Yeah.
Right, CMS is Medicare.
Yeah.
Right. So CMS is going to make its own independent evaluation, and they could decide to pay for it based on that. And, this is new technology. FDA has never seen this technology before. And we have been in deep discussions with them for several years now about what evidence base they would like to look at to understand what the benefits and risks of this are before making a decision on it. And we have committed to almost 400,000 participants in clinical trials, either completed or ongoing. No other entity that I know of has made that big a commitment. 400,000 people.
A significant amount. And of course, once Medicare, if Medicare approves, then all the other health insurance companies come on board, more likely than not.
Presumably, but remains to be seen.
Yeah. Wow. So Eric, final thoughts, and thank you so much for being on.
Sure.
How can people learn more about you or what you're doing and the company you're associated with?
Well, Grail has a website if you're interested in learning about what Grail's doing. I continue to lecture and publish. The prostate data that I just commented on was just submitted for publication this week. And
so this is hot off the press. The information you gave us, it's even before
publication, presented at the American Association of Cancer Research just about 2 weeks ago for the first time publicly. So it's important. It's an important safety signal to understand that we're not going to overdiagnose low-grade prostate cancer.
Sure. Yeah. Eric, thank you so much for being on.
Sure.
It's such a pleasure.
Likewise. Good to see you, Joe.
Good to see you. Thank you, everyone, for watching or listening to this special podcast episode with Dr. Eric Klein. I know this was useful to you and helpful to you so that you could be proactive, at least ask better questions to your practitioner. As always, we give you science-based, actionable information here at the Dr. Geo podcast. So hope you enjoyed it. Thank you, everyone, once again, and I'll see you next time. Much love. Talk next time. Bye. Thanks for tuning in to this week's episode of the Dr. Geo podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel on youtube.com/Geo Espinoza ND. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.